guys, welcome back to another video from the Aspiring Medics. My name is Yusuf, and in this video we're going to be talking about all things medical ethics. We're going to be going through abortion, euthanasia and a variety of other ethical dilemmas that are very likely to come up in your medical school interviews. If you're new here, don't forget to like, comment and subscribe. It's the best way of letting us know that you're enjoying these videos. We hope you enjoy.
My first question is, what are the laws surrounding abortion in the UK, and discuss the ethical implications?
Okay, so as far as I know, abortion is fully legal up to 24 weeks of pregnancy. So the mother has full autonomy at that stage over the pregnancy, and they can terminate it if they feel that's the right thing to do. After 24 weeks, I think abortion can only happen in quite limited circumstances. So, for example, if the pregnancy poses a danger to the life of the mother, then in that situation, doctors can carry out abortions. I also think maybe in Northern Ireland there are different laws there, because obviously everywhere there's a debate between the ethics of abortion or not. There's lots of sort of pro-life groups who think that no abortion should happen no matter what stage of pregnancy is, but as a whole in the UK, as far as I know, it's legal up to 24 weeks.
Mm-hmm. Great, thanks. What do you understand by the 4 principles of medical ethics, and can you give examples for each of them?
Sure. So, as far as I know, there is beneficence, which means that doctors and healthcare teams should act and do good, effectively. Then you have maleficence, which is do no harm. Those two are kind of interchangeable. It's hard to do one and not do the other. But just to give a basic example, I don't know, doing any operation really, or any simple operation, say, generally it will be in the interest of the patient. And although there is a degree of harm in surgery just through, say, the incision, or there's always a risk of infection, generally the beneficence outweighs the maleficence, and that's why it's carried out. Then we have autonomy, which means that the patient should have the right to decide what happens to them, which is quite self-explanatory really. For example, actually, like we just talked about earlier, women can choose to have an abortion up to 24 weeks in the UK. And yeah, I think autonomy is a really important one. As long as the patient is deemed to have the capacity to make that decision, or they consent to it, then yeah, patients have autonomy. And then you have justice, which is quite broad, but as I understand it, it means that the decision of healthcare staff should be, first of all, it should be legal, it should obey the laws of the land, but also it should be fair overall. So it's kind of looking at it from a taking a step back and thinking, is this just the right thing to do? Is this fair to all parties involved?
A patient refuses life-saving treatment. Discuss the ethical principles involved.
Okay, so here I think an important point to mention is the idea of consent. So if a patient refuses life-saving treatment, we have to bear in mind that they have autonomy, but are they in a position to give consent, if you like, to not have that treatment and then probably to die? So I'm not entirely sure. I can't quite remember how that's done, but I know there are certain ways that doctors can ascertain whether or not a patient has capacity to make that decision. It's a tricky one, because you have to really show empathy to that patient. Clearly, if they're refusing that treatment, they're doing it for a reason. So I think as a doctor, I'd be very keen to discuss with them their motives and empathise with why that might be the case. But also at the end of the day, ideally the doctor would be able to get the patient into a position where they do accept the life-saving treatment, because that would be saving their life, which is the optimal outcome for the patient.
Okay, and what factors would you consider?
Okay, so first of all, I would consider, well, first of all, obviously each patient is individual and their condition is individual. So it might be that the life-saving treatment is in itself invasive or traumatic, so that could be part of the reason why they're not accepting it. But the reason why they're not accepting it is definitely quite important. It could also be For example, I think Jehovah's Witnesses don't accept certain procedures, like maybe blood transfusions. So that would be a religious reason why they weren't accepting it. And yeah, obviously it's really difficult as a doctor because patients do have autonomy to make their own decision, but it's in their best interests to get the treatment and to stay alive. So there's a lot to consider.
Okay, and what factors do you think could influence capacity?
So I think, first of all, you'd have to be of a certain age in order to give, or in order to have capacity to make a decision. So I'm not sure of the exact age, but there'll be a cut-off below which your parents or guardians would act in your interests.
Yeah.
Also, you have to, I expect there's some kind of test, but I believe you have to be able to take on board and process information and then repeat it back and give a judgment based on that information. So there might be certain diseases, for example, Alzheimer's, where you're cognitively impaired and therefore you don't have the capacity to make a decision that's in your best interests. Also, if you're unconscious, you wouldn't have capacity to make a decision, so someone would have to do that for you.
Yeah, great, thank you. A 13-year-old patient goes to the GP by herself to ask for oral contraceptive pill. What do you do?
Okay, yeah, so first of all, it's obviously it's illegal to have sex under the age of 13, so that's something that's worth considering. I mean, the question really is why does she want the contraceptive pill? So clearly she either is having or is planning on having sex with someone. It's important to think about the age of the partner. If that partner is significantly older than her, then that could be sexual abuse. So that would be something that you would have to report to the police if it's an adult. I'm aware of the concept of Gillick competence. So assuming that 13-year-old, assuming that you know that they can take on board all the information that's relevant, process it, and then give you their decision, they have the capacity to take that contraceptive pill, and you as a doctor are allowed to give it to her. But you'd only want to do that assuming that everything else is okay, and that, like I said, it's not with an abusive older person. It'd be worth finding out about their personal circumstances, so whether she has a stable relationship with her parents or things like that, which might impact her decision to do this. It's also worth noting, I think, that she might not fully understand the different types of contraception. So oral contraceptive pills obviously would prevent pregnancy, but they wouldn't stop sexually transmitted diseases. So it would be important to inform her about that, and that really things like condoms should be used to prevent transmission of diseases.
A woman has a family history of breast cancer, and specifically the daughter would like to do a genetic test for the BRCA gene. The BRCA gene increases your risk for breast cancer. What are the ethical issues involved, and what would you do as the doctor?
Okay, so first of all, the daughter has the right to get that test and find out if she has the gene, because if so, then she'd be aware of her higher risk of having breast cancer, and that would influence her decisions. But at the same time, the mother has the right not to know whether or not she has the gene if that's what she wants. So it's definitely a tricky one. Also, I think I read somewhere that the BRCA gene, it increases the risk of breast cancer, but also some other cancers. I think ovarian cancer is one of them. So that makes it even more complicated, because if she does have the BRCA gene, then she might be at greater risk of other types of cancer, which, for example, might be harder to screen for, and so that would have further implications about the next steps. Obviously, for breast screening, you can do that with things like ultrasound, I think, and that wouldn't be a particularly difficult procedure. But if she did have the gene, then that would make it quite complicated. So obviously the doctor would have to weigh these things up, but presumably if the daughter found out, then the mother would also find out. So it's really a case of deciding whether or not it's better for the daughter to know and the mother to know, or neither. And I think balancing up both sides, I would probably say it's better to do the test and for the daughter to find out. But the complication of possibly a greater risk of several cancers also makes it important for the daughter to find out.
You are a GP. A HIV patient reveals to you that they have not told their partner about their HIV diagnosis. Discuss the ethical principles involved in what you would do in this situation.
Okay, so obviously HIV is a sexually transmissible disease, and so it would be important that the partner does find out that their partner has HIV, because obviously if they didn't, then they might, for example, have sexual intercourse and contract HIV, which would have lifelong implications possibly. HIV doesn't have a cure, so it's very serious. It's obviously, you'd have to try and find out why the person with HIV doesn't want their partner to know, because that does seem quite strange. So there might be something further in there. Maybe they might be having trouble in their relationship, or maybe the person with HIV has some sort of mental health issue, but it would definitely be worth taking that into consideration. I think that if the patient continued to refuse to tell their partner that they had HIV, then in that situation it would be appropriate to breach the autonomy and to tell the partner yourself, because like I said, HIV is a sexually transmissible disease, and you wouldn't want the partner to contract it. It's, you know, that's a severe risk to others, so that would warrant breaking confidentiality, I think. But it would be important to tell the patient that you were doing so, just to minimise the impact of that on them. It's definitely a delicate situation.
When is it appropriate to break patient confidentiality, and have you researched any examples in which this has been the case?
Yeah, so as I understand it, it's acceptable to breach confidentiality as a doctor or healthcare professional if the patient is themselves at risk, or if they're putting someone else at serious risk. So, for example, maybe if they're suicidal and they tell you that, then it would be appropriate to breach confidentiality and tell the relevant people to stop them from taking their own life. But that being said, it's also important to, I know it keeps coming up, but it's important to empathise with the patient, because breaching confidentiality is very serious, so it should really only be done under exceptional circumstances like that. Also, if they pose a risk to public health, so if the patient had, for example, tuberculosis maybe, I'm not sure of the specific diseases, but I think if they had a disease which could cause an outbreak, then that would probably warrant breaking confidentiality to prevent that. Although again, you'd want to make sure that you treat that with care, and probably also inform them that you were going to breach that confidentiality, because that would be in their best interests.
Great, thank you. Is it right for junior doctors or medical students to provide substandard care in electives in order to teach and learn?
Okay, yeah, so that's an interesting question. Obviously, the first priority of doctors and healthcare teams is to provide the best care possible to the patient, so that should always be the first priority. But at the same time, doctors have to learn somehow. They have to learn by treating patients, and that will inevitably involve making some mistakes at that early stage. So I think there has to be a degree of allowing junior doctors to try and do their best, and possibly not always make the right decision, because from that they'll learn and they'll improve. I've spoken to a few doctors who have told me, yeah, of course we make mistakes, we make a lot of mistakes, but when we do, as long as you acknowledge it, make sure that it doesn't have any implications on the patient's health or treatment, and then reflect on that and improve next time, then it's okay. But also, on the other side of the coin, you don't want to just let junior doctors loose on patients and cause an unnecessary number of mistakes. So I think there needs to be a degree of oversight and supervision as they progress and improve, just to make sure that the patients get the best care and that the doctors learn.
Good. So you're thinking about operating within the limits of what they actually are able to do as well in terms of their responsibilities. You
Yes.
don't let a medical student let loose at doing a heart transplant, for example.
No, absolutely. There needs to be a sort of progressive increase in what they're allowed to do as their skills develop. And yeah, there needs to be restrictions.
Good. And what else would you want to consider alongside that? When you get any operation, who obviously has to agree to an operation?
Well, of course, the patient
Yep.
has to agree. So yeah, that's a good point actually. So I think it would be important as doctors to inform the patients that that you're junior and that you're learning, and then the patients might say that's fine, go ahead, or they might express some concerns about that, in which case it would be inappropriate to let junior doctors do those things, and it should be given to a more senior doctor if that's what the patient's more comfortable with.
Great, thank you. A parent brings in her 14-year-old girl who's being bullied. Her 14-year-old girl would like cosmetic surgery, but her mother strongly disagrees. You, as a GP, need to have a consultation with the both of them. What is going to be your approach?
Okay, yeah, that's an interesting question. So I think I seem to keep saying this in every question, but it's important to empathise with the patient. Obviously, bullying is horrible. So as a GP, you want to make sure that the daughter knows that you understand her situation and that it can't be allowed to continue. I think I'm not even sure if it's legal for children of that age to have cosmetic surgery. Is that? Yeah. So I think, firstly, it probably wouldn't be legal for her to have cosmetic surgery, but also that wouldn't really be getting to the root of the problem, because clearly the issue is that she's being bullied, and that's causing some distress, maybe some mental health issues, and that's what's prompted her to seek this treatment. Clearly the bullying is quite severe if she's demanding cosmetic treatment, because she presumably realises that it's quite a serious thing and it has a few risks and costs. So it would be important to speak with her about that, and also it would be important to speak to the mother and try and firstly find out her perspective, but also to work with both of them to stop the bullying would be the most important thing. So you could point them in the direction of certain services, maybe give the daughter counselling or something to help her get over it, but also it probably would be best to speak with the mother about stopping the bullying. If it's at school, maybe speaking to the head teacher or something like that. But certainly cosmetic surgery wouldn't be the correct solution.
And what do you think could be the consequence of someone actually getting bullied?
Well, bullying, the main consequence is psychological. Mm-hmm. It's quite traumatic, I think, depending on how they're being bullied and how long it's been for. That could vary, but it could be quite profound. If you were bullied over a long stretch of time, say at school, that might not only affect your mental health in terms of your self-confidence, mm-hmm. or you might end up losing friends because of it. Mm-hmm. It might put you off school, so it would have an adverse effect on your education. So there's probably a whole cascade of effects of bullying.
And what else could be the cascade of effects of bullying? For example, if it was over, say, her weight.
Yeah, that's true. So if the bullying was about her looks in terms of her weight, then that might encourage her to stop eating. So that could lead to things like anorexia, which could lead to some quite serious health problems if that wasn't taken care of.
Yeah, absolutely. Should the NHS fund cosmetic surgery that has gone awry, i.e. that has gone wrong?
Okay, yeah, so I think immediately my answer would be yes, because people might choose to have cosmetic surgery, and that's kind of a separate issue. But the fact is that the surgery's gone wrong. They've ended up with some sort of complication. Their appearance is probably quite different to what they were sold on for the cosmetic surgery, and no matter what the motivation was or why the cosmetic surgery took place or what was done, it's the responsibility of the NHS to treat all patients regardless of their financial situation, etc. So I think the NHS really should be treating cosmetic surgery that's gone wrong. I mean, obviously every argument has a counter argument. I think probably people might argue just that the NHS only has so much funding, and there's maybe more urgent things that need funding. You know, there's life-saving cancer operations and so on, which might warrant getting the funding before things like fixing cosmetic surgeries gone wrong. But really, as a principle, I think the NHS should treat those.
Okay, so what could be examples of cosmetic surgery?
There are things like I think liposuction might come under cosmetic surgery. I've not come across any ways of that going wrong, but I'm sure it could, and that could it might not only actually have an aesthetic implication, but that could also lead to further health complications, maybe through infection or something like that. So that's another reason why it should be treated.
Is that a big risk, infection?
Infection is a risk to varying extents for all surgeries. I'm not sure about liposuction in particular, but I think for surgeries that have gone wrong, infection probably is one of the main reasons that it might go wrong.
Yeah, so it's got a fairly small chance, but if you do get an infection, it's going to be severe, right? So why is that a consequence, and why would you want to treat that early?
Well, firstly, the earlier you treat an infection, probably the easier it is to get it under control and to get rid of it. So so the NHS really ought to be, as much as possible, treating these things as early as possible. That would also save them money in the long run by not having to spend as much on treatment. But primarily the benefit would be less harm to the patient, because infections would cause symptoms to accumulate, if you like, as they got worse.
And what could go wrong in surgery? You've mentioned infection, but going wrong could also mean not having the same cosmetic effect. Should that be then operated on by the NHS?
Yeah, that's a tricky one, because I suppose there are varying extents to which it might go wrong. So it might just be that the surgery looks ever so slightly different to what the patient agreed to, in which case it's kind of a grey area. It's probably harder to determine whether or not it's gone wrong, or whether or not it's just sort of imperfect or slightly different. But equally the cosmetic surgery might go wrong in a more obvious way. I'm just trying to think of an example. I know people get sort of fillers in their face and cheeks and so on, so it might be that they're slightly different, or they might be more obviously different and look wrong in the eyes of the patient. In which case, even if it's not an infection or something, it could be quite harmful for the patient's mental health and sort of self-image if they think that they don't look right in that way. So it would still be, in my mind, it would still be worth operating on, but it's harder to justify maybe.
Yeah, exactly. Harder to justify when you're thinking about limited costs and limited resources, and particularly when anything to anybody that has body dysmorphia would be, viewed as imperfect. So would they potentially want to consider counselling and other methods first before they consider something like that? Good, thank you.